Good afternoon to all, and I hope everyone is doing fine. I welcome everyone for the Kauvery Spotlight Series 20. Today, we are going to discuss one of the important topic, that is what we are managing in our day-to-day practice. That is the storm of viral infection which is going in this season, and how to manage that viral infection in OPD and inpatient and in ICU ward. And in this discussion, uh, there there are two well-known pediatric pulmonologists from the Delta region, and Dr. Karthikeyan and Dr. Manoj. Both of them are joining with us. So let's go into the presentation. So we know over the last 2 to 3 months, we are seeing a huge surge of viral respiratory infection, both in our OPD practice, in ward, as well as in ICU. And the trend is same all over the Tamil Nadu. Even the trend is same in all over the southern part of India. And children less than 5 years, predominantly infants, are commonly affected with bronchiolitis, pneumonia, and acute exacerbation of wheeze. And admissions in the ward has increased by even up to 40 to 60%. Since most of the infections are viral, physicians are often confused whether they have to start antibiotic or not. So this panel discussion is about, in this discussion, our panelists are going to give a clear evidence based as well as practical approach to how to diagnose these respiratory infections in OPD practice, and when to hospitalize, when to escalate the respiratory support in PICU, and what is the current role of antivirals, nebulization, steroids, and how to prevent these respiratory viral infections. So let's start with epidemiology of the viral infection. So, question to Dr. Manoj. So, sir, what viruses are currently dominant in this season, and what pattern do you see in OPD and IP admission?
So each year we notice a trend of different virus which is predominantly causing the issues. So a couple of years back it was adeno, and last year most people would know that mycoplasma was the most predominant of the infections. So now it is back to the past. So this year almost 50 to 60% of all infections, if you do a swab, you are getting RSV. So RSV is the most common infection, and the current pattern that I see in our OPDs, wards, and even the ICU is that the younger children, those less than 1 year, especially those less than 6 months, are coming in much sicker. And the second pattern that I've noticed is even in those milder bronchiolitis, mild to moderate bronchiolitis, the cough is taking extra bit of time to settle. Usually by seventh or eighth day, the cough settles. The child is otherwise well active, feeding well, but the cough is even taking 10, 15 days to settle. So that is the pattern that I've noticed with RSV in this season.
Thank you, sir. As he said, exactly, the RSV which behaves in the pre-COVID area is behaving differently nowadays. And, question to Dr. Karthikeyan, sir. Sir, what age groups are predominantly affected, and children with what type of comorbidities are mostly affected in this viral surge?
So, as Manoj said, less than 6 months, mainly infants are affected more in the season, especially in less than 3 months. Even well thriving child is getting affected because of RSV and influenza. And comorbidities, as always, for all respiratory infections, they are with the chronic lung disease, especially with the asthma child or with any nephrotic syndrome, renal diseases, chronic heart disease, PST, AST child. They are all more probably affected. And we are seeing immunodeficient child also getting affected with these viruses. So it's these are the common age group, but more than 5 years, it's very less only compared to infants.
Thank you, sir. Let's move to the clinical features of respiratory viral infection. Uh, question to Karthikeyan, sir. Sir, how to differentiate clinically RSV infection from influenza infection in children? Because nowadays we are seeing both influenza also as well as RSV in our OPD practice.
In most of the time, less than 6 months, RSV predominates. But what we see in the season is RSV, coryza will be less, and there will be mild or no fever at all. Cough is predominant in RSV. But in if you see influenza starts with the abrupt onset of high grade fever, coryza, and cough and respiratory distress. So high grade fever, cough, and coryza, always think of influenza. If there is a mild or low grade fever or even no fever at all, along with the significant cough with minimal or no coryza, think of RSV. but more both presents with respiratory distress. In severe infections, more will present samely only. So we can't find the difference between RSV and influenza.
So, question to Dr. Manoj, sir, are current viral infections presenting more severely than previous years? And how to differentiate viral V's from asthma exacerbation in older children in our OPD practice?
So the first part of the question, yes, definitely, the RSV of this year is much worse than what we are used to. So, and as both I and Dr. Karthikeyan mentioned, younger children, they're rapidly deteriorating. First day in the ward, second day they are almost going into the ICU. So yes, it is more severe this year. Regarding differentiation between viral V's and asthma exacerbation in older children, you have to rely on the history. So, I mean, the old Gina used to have a nice tabular column to elucidate that. If the child prolongs with cough after a viral illness, if the child is having frequent episodes of cough, each requiring nebulizers to get better, then you're looking at probably a child with asthma who has come in with an exacerbation. On the other hand, if the child is more or less well, so parents say that occasionally 1 or 2 times we have nebulized, probably that is a viral triggered wheeze. Whereas if the parent says every time when the child coughs, I go and get nebulized, you're probably looking at an asthma exacerbation. So that is a simple tool on your OPD.
So as Karthikeyan sir said, the basic difference between RSV and influenza infection is influenza infection, in addition to respiratory symptoms, it can also present with systemic symptoms like high grade fever, myalgia, and loose stools like that. So moving from clinical features to investigations which we can done in our OPD practice. So Dr. Manoj, how useful are that sepsis biomarkers like CRP, procalcitonin, and a complete blood draw? Doing that in OPD practice to differentiate viral from bacterial respiratory infection.
So if you want to differentiate viral from bacterial, I think the first, second, and the third most important thing are all history and clinical examination. So in a child who has fever for 1 day, completely well, X-ray is more or less okay, you hear crackles bilaterally, even if CRP is 200, I'm going to think viral infection. So first is history, second is examination, third is X-ray. So based on this, you can form a clinical diagnosis whether it is bacterial or viral. In scenarios where it is a bit shady, so child has received antibiotics, uh, child is a bit dull, you find some infiltrates on the X-ray, you're not sure if it's an evolving pneumonia. In those instances, your CBC, CRP, and Procal may value add to your clinical diagnosis. But again, in a child with 6 days of fever, even if a CRP is negative, I'm going to think bacterial. Whereas in a child with only 1 day of fever, afebrile sense, even if CRP is 100, I'm going to think viral. So it adds to your clinical diagnosis. It doesn't change your clinical diagnosis.
So, Dr. Karthikeyan, what are the laboratory markers which helps to differentiate, as you said, clinical features? Like what are the laboratory markers which helps to differentiate RSV from influenza infection?
So obviously viral infections, most of the time if you take a blood count, so total count will be normal or mildly elevated. But in influenza, in what we see in the season is influenza mostly present as leukopenia along with thrombocytopenia like dengue picture. But there will be cough, so you can differentiate that. So, but in RSV, the counts will be mostly normal or mildly elevated with lymphocyte predominance. In influenza, leukopenia, thrombocytopenia may be present or not, and along with the lymphocyte predominance. And if you see CRP, almost in RSV around it will be around 20 to 30, but it can influenza, it can go up to even 50 to 60. But again, as Manoj said, it depending on the clinical features history, then only you can see the lab markers. So lab markers just support a diagnosis, but it is not a simple tool. It's a only tool to differentiate RSV from influenza infection. Even in influenza, you can see transaminases, mildly elevated liver enzymes also you can see in this. So they are the most prone, and influenza may trigger even HLH like symptoms. So that's the differentiating.
Thank you. So, Dr. Manoj, when do you advise chest X-ray? For example, a child presenting with cough, coryza, and mild fast breathing. On auscultation, you are getting a minimal occasional cramps and wheeze. Will you advise chest X-ray for that child in your OPD?
So being a pulmonologist, I'm doing chest X-ray for all children that are referred to me. But for practicing pediatricians, what I would say is if the child is clinically well, on clinical examination you feel that the child doesn't warrant admission, you're going to wait and watch, I would say chest X-ray is not required. You can just wait and watch, and if there are any red flags, you can do an X-ray. Whereas if it's a bronchiolitis child that you're planning admission, I would recommend documenting a chest X-ray just to be sure that we are dealing with only a bronchiolitis, especially in younger children. Maybe for a 2-3 year old, I would wait and watch. Say if you are having a 2-month-old child with distress which you are contemplating admission, I would want a chest X-ray just to be sure that there is nothing else.
So, as you said, some of the red flag signs. Could you please elaborate? What are the red flag signs you will think?
So if the child is failing to thrive, if the child is having persisting fevers, child is having severe distress with subcostal retraction, child is hypoxic, I would definitely want an X-ray.
So, as Dr. Manoj said, doing routine chest X-ray in OPD practice for a mild case of acute bronchiolitis is not recommended. Even guidelines also doesn't recommend. But if you have any atypical features as persistent high-grade fever spikes, on auscultation you have any localized findings and failure to thrive on other symptoms, then you can go for chest X-ray. So another most important investigation you have to consider is that doing respiratory viral panel. So Karthikeyan sir, when should a pediatrician order respiratory viral panel? And what is the role of single virus panel versus single virus PCR versus multiplex PCR?
ஸோ ஓபியில் நம்ம பார்க்குறது எல்லாமே வைரல் தான். ஸோ எல்லாத்துக்கும் பேனல் அட்டன் பண்ணால் அதுக்கப்புறம் பேஷண்ட்ஸ் யாருமே வரமாட்டாங்க. ஸோ ஓபியில் இட்ஸ் பெட்டர் டு அவாய்ட் மல்டிப்ளெக்ஸ் பேனல். ஸோ நம்ம ஒரு சைல்டு ஒரு சிக் சைல்டாக இருக்குது, வெதர் நான் எனக்கு வந்து ஒசல்டாமர் போடுறதா வேணாமா, ஸோ இது ஃப்ளூ தானா அப்படின்னு பார்க்கறதுக்கு வேணால் நம்ம பேனல் பண்ணலாம். ஸோ சிங்கிள் வைரஸ், ஸோ நான் ஒசல்டாமர் ஸ்டார்ட் பண்ணுறேன், அஃபீஷியலாக நான் பேரண்ட்ஸ்ட்டு டயக்னோசிஸ் எக்ஸ்பிளைன் பண்ணுறேன், எனக்கு இது இன்ஃப்ளூ தான், நான் அதனால் ஒசல்டாமர் ஸ்டார்ட் பண்ணுறேன் அப்படின்ற பேரண்ட்ஸ்க்கு நம்ம பண்ணலாம். இல்லைனா அதர்வைஸ் நாட் ஆல் நீடட். பட் டெஃபினெட்லி இந்த ஐசியூ செட்டப்ஸில் சிக் சில்ட்ரன் இருக்காங்க அப்படின்னா, ventilated child இருக்குன்னா it's better to go for multiplex PCR rather than single virus panel. So single virus panel mainly to establish a diagnosis or to whether to start oseltamivir or not. பட் இப்போ ஆர்எஸ்வி பொக்கா வைரஸ் எல்லாமே வந்து நேசோஃபெரிஞ்சியல்லே வந்து ஆல்மோஸ்ட் இட் ப்ரெசன்ட் ஃபார் 6 weeks. ஸோ பட் இன்ஃப்ளூயன்ஸா, அடினோ வைரஸ் இதெல்லாம் மல்டிப்ளெக்ஸில் பார்த்து பாசிட்டிவ் வந்துச்சுன்னா இட்ஸ் a true positive. So that can be considered. So mainly to whether to decide a treatment, whether it's going to alter your treatment அப்படின்னா இந்த மல்டிப்ளெக்ஸ் பிசிஆர்லாம் பண்ணலாம். Otherwise not at all needed. And definitely in ICU setup, it's definitely needed to decide on the treatment.
As you said, it's going to alter your treatment.
Only so, if it is going to alter your treatment.
So in what way could you please?
இப்போ ஒன்றுமே இல்லை, நம்ம பண்ணுறோம் இன்ஃப்ளூயன்ஸா இருக்குது, எனக்கு ஆர்எஸ்வி இருக்குது அப்படின்னா, இப்போ நம்ம ஃப்ளூ இருக்குது அப்படின்னா நம்ம வி கேன் கோ ஃபார் ஒசல்டாமிவர். ஸோ அதே மாதிரி தான் அடினோ வைரஸ்க்கு வந்து ஈவன் போஸ்ட் அடினோ வைரல் பர்சிஸ்டண்ட்டாக ரெஸ்பிரேட்டரி டிஸ்ட்ரெஸ் இருந்துகிட்டே இருக்குது அப்படின்னா திஸ் அடினோ வைரஸ் வில் டேக் லாங்கர் டைம். ஈவன் அடினோ வைரல் போஸ்ட் அடினோ வைரல் பூப்பாக சேஞ்ச் ஆகிறதுக்கு பாசிபிலிட்டிஸ் இருக்குது. ஸோ அந்த விஷயத்தில் ப்ளஸ் ஈவன் அடினோ வைரஸ் இல்லை சம் சைல்டு வித் அடினோ வைரஸ் வில் பெனிஃபிட் ஃப்ரம் இம்யூனோகுளோபுலின். ஸோ அது மாதிரி டைமில் நம்ம டிசைட் பண்ணுறதுக்கு இது யூஸ்ஃபுல்லாக இருக்கும்.
So coming to the management of this RSV infection in OPD. So Dr. Manoj, could you please tell what is the role of hypertonic saline nebulization in RSV infection?
In OPD practice, there is no role for hypertonic saline nebulization. Even Cochrane yearly in their reviews change their stance on hypertonic saline. When I last read in 2024, it says that it does reduce ICU admissions, it does reduce hospital stay, but it's not a wonder drug. It's not like levosalbutamol for wheezing. So it at best has a modest effect on reducing distress, promoting airway clearance. So in a child who you are seeing in an OPD, which you are probably going to send back home because the child is feeding well, there's no distress, I don't think there's any need for giving hypertonic saline. It is not going to alter the course of the illness. So for strictly OPD practice in mild bronchiolitis, I would say no to hypertonic saline.
But again, if when child presents with cough and mild distress, most of the parents want the child should get nebulized. So when should we use nebulized bronchodilators in viral infection, and which children actually benefit from this bronchodilator nebulization?
Actually which children actually benefit nu போறது நம்ம pediatricians எல்லாமே பெனிஃபிட்டட் தான், அதுல ஒரு டவுட்டே கிடையாது. பட் மோஸ்ட் ஆஃப் தி டைம் ட்ரூவா இப்போ ஸ்டடீஸ் மனோஜ் சார் சொன்ன மாதிரி ஸ்டடீஸ்லாம் பார்த்தோம் அப்படின்னா எதுக்குமே ரோல் இல்லை தான். பட் இஃப் யூ ஆர் ஹியரிங் வீஸ், நான் பார்க்குறேன் வீஸ் இருக்குது அப்படின்னா இட்ஸ் அ ட்ரையல் நெபுலைசேஷன் தான். So trial nebulization கொடுத்த response இருக்குன்னா you can continue nebulization. If there is no response to nebulization, there is no point in giving nebulizations repeatedly. அதே மாதிரி தான் எக்ஸ்பெஷலி டிவோலின் கொடுத்தா இன்னும் பெட்டராக இருக்கும், டெஃபினெட்லி கிடையாது. ஸோ சால்புட்டமால் இஸ் அ பெட்டர் ப்ராங்கோடைலேட்டர். அண்டு எனக்கு தெரிஞ்ச பாயிண்ட் முத்துவேல் சொன்னது வந்து ஈவன் அந்த டிவோலினே இப்ரோட்ரோபியம் யூஸ் பண்ணால் வித்தின் 24 ஹவர்ஸ்க்குள்ளார யூஸ் பண்ணால் தான் பெட்டராக இருக்கும். மோர் தென் 24 ஹவர்ஸ்க்கு அப்புறம் டிவோலின் திருப்பி திருப்பி கொடுக்கறதுல அர்த்தமே கிடையாது, பிகாஸ் மஸ்கர்னிக் ரெசெப்டார்ஸ்லாம் உள்ளார போயிடுறதுனால. ஸோ ஒன்லி இஃப் யூ சஸ்பெக்ட் இஃப் தெர் இஸ் அ வீஸ், கிளியர் கட் வீஸ், கொடுத்தா ரெஸ்பான்ஸ் இருக்கா இல்லைன்னா ஒரு சிங்கிள் டோஸ் நெபுலைசேஷன் கொடுத்து ரெஸ்பான்ஸ் இருந்துச்சுன்னா யூ கேன் கண்டினியூ, அதர்வைஸ் இஸ் நாட் அட் ஆல் நீடட். சில்ட்ரன் பெனிஃபிட் ஆகிறது காஃப் பெருசாலாம் குறையாது. டெஃபினெட்லி காஃப் வில் கோயிங் டு லாஸ்ட் ஃபார் 2 to 3 weeks. ஸோ 50% வில் ரெடியூஸ் இன் 2 weeks and 90% வில் ரெடியூஸ் இன் 3 weeks. ரிமைனிங் 10% வில் செட்டில் இன் 4 weeks. ஸோ ஆப்வியஸ்லி நம்ம காஃப் நிறைய இருக்கும், 4 weeks இருக்கும், அது ஒரு ப்ரொடெக்டிவ் ரிஃப்ளெக்ஸ் தான் சொல்லி பேரண்ட்ஸை கன்வின்ஸ் பண்ணுறது தான்.
Some of us are using steroid nebulization in OPD, like budesonide nebulization. So what's the role?
ஸோ அதுவுமே பியூடிகார்ட் நெபுலைசேஷனுமே ரோல் இல்லை தான். ஸோ கிளியர் கட் வீஸ் அப்படின்னா நம்ம வந்து ஓரல் ஸ்டீராய்ட்ஸ் ஆர் ஐவி ஸ்டீராய்ட்ஸ் கொடுக்கலாம் ஃபார் வீஸ்க்கு. பட் தெர் இஸ் நோ ரோல் ஃபார் பியூடிகார்ட் நெபுலைசேஷன் ஃபார் ப்ராங்கியோலைட்டிஸ். ஈவன் நானுமே ப்ராங்கியோலைட்டிஸ்க்கு ஏதாவது பியூடிகார்ட் கொடுத்தா நல்லா இருக்குமா, ரெஸ்பான்ஸ் இருக்குமாலாம் ட்ரை பண்ணியிருக்கேன். ஏன்னா இன்ஃப்ளமேஷன் தானே ட்ரை பண்ணால் என்னென்னலாம் பண்ணியிருக்கோம், பட் பெருசாக எதுவுமே ரெஸ்பான்ஸ் இல்லை. அதுவாக பேரண்ட்ஸ்ட்டு அழகாக ஃபஸ்ட்டு 2 days காஃப் இருக்கும், 3 days 4 days 5th டேல அதிகமாகவும் ரெஸ்பிரேட்டரி டிஸ்ட்ரெஸ் வரதான் செய்யும். அதுக்கப்புறம் 5th டேக்கு அப்புறம் இம்ப்ரூவ்மெண்ட் இருக்கும். இட் லாஸ்ட் ஃபார் 2 weeksன்னு சொன்னால் அது கண்டிப்பாக கேட்டுக்கிட்டு போகும்.
As they said, some studies have shown hypertonic saline nebulization have decreased the IP admission when you tried in OPD practice. And as Dr. Karthikeyan said, there is no role of nebulized bronchodilators in management of bronchiolitis because the pathophysiology itself is different. But if there is a family history of bronchial asthma, if it is a recurrent wheeze, then you can try giving bronchodilator. It is like a trial and error method. If there is a response, you can continue. So coming to the next question, that's to Dr. Karthikeyan, sir, how do you decide which child can be safely managed at home versus which child need observation and admission in hospital?
So the child is able to take oral feeds, you can straight away send the child to home. That's a simple. Even though if there is a respiratory distress, mild respiratory distress. If there are red flags, that is severe respiratory distress, not able to take oral feeds, hypoxia or cyanosis, or the child is having seizures or high grade fever, not having anything, so it needs definitely admission. And anxious parents, it's better to observe. So there is no point in giving trial nebulization for this, as already Manoj said. So if the child is able to take oral feeds and passing urine well, you can straight away send the child to home, even if there is a minimal respiratory distress.
So most of the parents ask that one of the common question is whether they can nebulize the child at home. So what is the role of home nebulization and steam inhalation in the current viral illness?
So steam inhalation is a definite no. I think even IAP has put out a statement saying that steam inhalation should be avoided because there's a risk of facial burns and other complications in children. So steam inhalation is a strict no. For bronchiolitis, I would not advise any home nebulizations. There is no role. Even in IP, 3% saline has at best a modest role. For wheezers, for known wheezers on inhalers or whatever, who have a home nebulizer, what I would advise is at max 1 dose of nebulizer. So you try to control with inhalers. Say in the middle of the night, if the child is coughing a lot, I mean in younger children the technique won't be as proper. What I would say is you can give 1 dose of home nebulization at max. Beyond that, if the child is still having cough or any other issue, you have to meet a pediatrician in the morning as early as possible.
Even that 1 dose of nebulization is a மனத்திருப்தி. அந்த ஒரு டைம் கொடுத்தா பெட்டர் ஆயிரும்னு அவங்களே நினைப்பாங்க, குழந்தையும் இருமுறது கம்மியாயிரும்.
So as they said, children who are alert, active and accepting orally well and having only minimal distress and maintaining saturation can be safely sent home. And we have to explain the danger signs, what they have to watch for. Whereas children who are having high grade fever, dull looking, not accepting orally and having distress, not maintaining saturation and very lethargic, they need to get admitted. And Dr. Manoj clearly said there is no role of home nebulization and steam inhalation in the management of bronchiolitis. Then coming to one of the important questions, when we see prescriptions, lot of prescription, most of us nowadays are prescribing oseltamivir frequently in OPD basis. So, what is the exact role of oseltamivir in children with influenza? When we have to start oseltamivir, and is there any contraindication for starting oseltamivir?
So, oseltamivir is a neuraminidase inhibitor. So, it blocks the rapidly dividing influenza virus. Okay. So, if at all you are going to start oseltamivir in a suspected case of flu, it should be within the first 3 days. So, in a clinical scenario, if you are sitting in the OPD, almost every child is going to come on day one, day two with cough, cold, running nose. So, it is, and if the child is not sick, you are not going to do a nasal swab or anything. So, in clinical scenario, oseltamivir either you start for everybody or you start for nobody, because you will not be able to find the organism. So, in a sick child, so the child is coming on day one with whatever reason, breathing fast and all, I would say please start oseltamivir. Whereas in an OPD basis, I would personally, I would not start oseltamivir. I would wait and watch. Main reason is that oseltamivir causes a lot of gastric disturbance, so it is associated with a lot of vomiting. Child who's already coughing now gets vomiting, and the parents get more anxious. So in OPD management, I refrain from starting oseltamivir.
But in which children oseltamivir is actually indicated in OPD practice?
So the most common scenario where I do start oseltamivir is if the sibling is diagnosed with a flu, and this child has a cough, cold, and a fever. I would upfront on day one start oseltamivir. So that is a clear-cut indication. Other than that, if you find someone who is willing to do a nasal swab on day one to diagnose influenza, then you can definitely start oseltamivir.
Another common thing we observe is, in addition to oseltamivir, the child might be receiving one more antibiotic also. So, what is the role of oral antibiotic in current respiratory viral epidemic?
So it can be either influenza or RSV. Could be secondary bacterial infection, most commonly Streptococcus pneumoniae, Streptococcus pyogenes, Staph aureus, இதுதான் காமனாக இருக்க போகுது. பட் வித்தின் ஃபஸ்ட்டு 2 டேஸில் நம்ம ஸ்டார்ட் பண்ணுறது யூஸே இல்லை. ஸோ ஒரு சைல்டு இம்ப்ரூவ் ஆன சைல்டு ஒரு 3 days 4 days திருப்பி டிட்ரேட் ஆகுது, இல்லைனா வந்து ஒரு இப்போ போன வீக் தான் இன்ஃப்ளூயன்ஸாவால் அட்மிஷன் ஆகி டிஸ்சார்ஜ் ஆயிருக்காங்க, திருப்பி ஒரு 1 week சைல்டு அகைன் டெவலப்ட் ஹை கிரேட் ஃபீவர். Now you can think of secondary bacterial infection. So if you think of clear cut as a case of secondary bacterial infection, now ICU நம்ம அட்மிட் பண்ணுறோம். ஸோ அப்போ சிக்காக இருக்கிறப்ப ஆப்வியஸ்லி தே ஆர் மோர் prone for secondary bacterial infection. So overall only 3 to 5% children in OPD child will get a secondary bacterial infection, but in ICU it can goes up to 30 to 40%. So அது மாதிரி கண்டிஷனில் you can start, you can cover Streptococcus pneumoniae, Staph aureus. So amoxiclav is the better drug. If the child deteriorate after 3 to 4 days or after 2 weeks, 1 to 2 weeks of influenza infection.
So, as they said, oseltamivir is not indicated for everyone. You can consider giving oseltamivir children who are in contact with a known case of flu, and if you are clinically suspecting flu and the children is having some comorbidities or immunocompromised or underlying chronic lung disease and chronic heart disease, in those children you can consider starting oseltamivir in OPD practice. And as Dr. Karthikeyan said, there is no role of starting oral antibiotic upfront in a suspected primary viral infection. If the child presents later after 4 to 5 days with persistent fever, or earlier recovered and now presenting again with fever, that time we can consider secondary bacterial infection. So, what secondary bacterial infections are common in those children, sir? Is there only pneumonia is common, or any other
No,
like ear infection and all?
it can present as heart dysmedia itself. So even influenza is present as heart dysmedia in 10 to 20% child. So most commonly heart dysmedia, pneumonia, even sinusitis. So some rare children get with the X-ray changes. So that's the common thing. So most commonly it is affected with the Streptococcus pneumoniae and Staph aureus. In children, if some children is having skin infections, previously at the influenza vaccine, you can think of MRSA infection also.
So, one more important topic, that is giving cough suppressant. So, what is your approach in prescribing cough suppressant and mucolytics in young children with bronchiolitis?
I do not prescribe cough suppressants or any cough medicines of any sort, especially in infants with cough of any reason. So, be it wheeze, bronchiolitis, upper airway cough, pharyngitis, whatever it is, I do not prescribe any sort of cough syrups. My job has become easier after what has happened a couple of months back in Madhya Pradesh. So if I tell parents, see what happens with cough syrups, I'd rather not give. They're sort of okay. So cough, as we all know, is a protective mechanism. So in bronchiolitis, there is secretions in the airway which the child has to cough out. So even theoretically speaking, suppressing the cough is counterproductive. You're basically causing mucus plugging by giving cough suppressant, and none of the cough suppressants actually work in bronchiolitis. So I do not prescribe any cough suppressant.
So as he said, based on the recent incidents, that is that fixed drug combinations and all, it's not recommended. But won't you consider even a single drug, for example, a cough suppressant, second generation antihistamine, or
In children more than say 8 or 9 months, I do give second generation antihistamine. So either fexofenadine or cetirizine I do give. Whereas in children less than, especially less than 7 or 8 months, I do not give any cough suppressant. I just give nasal drops, wait and watch.
but if the mother says my child is continuously coughing, during feed the child is coughing again, and the cough is affecting the child's sleep, at that time what will you do?
I would tell them to get admitted.
Actually simple. So கடவுள் வந்து
Better for the pediatrician, better for the child.
counseling.
The another important thing is counseling. As Dr. Karthikeyan already said, the cough lasts for prolonged time. So how will you counsel the parents in this scenarios?
சிம்பிள். இந்த கடவுள் மூக்கு படிச்சிருக்கிறதே சளி ஒழுகிறதுக்காக தான். இல்லைன்னா உள்ளாரே இருந்துட்டா என்ன ஆகுறது? ஸோ மனோஜ் சொன்ன மாதிரி தான், உள்ளாரே இருந்துட்டா ஸோ தட் இஸ் கோயிங் டு காஸ் மோர் ஹார்ம். ஸோ அது ஏதாவது வெளில வந்து தான் ஆகணும். ஸோ அதுக்காக தான் இந்த காஃப் ஆகிறது ப்ளஸ் இந்த மூக்கு உழுகிறது எல்லாமே அதுக்காக தான். அந்த ஓட்டையெல்லாம் அடைச்சிட்டா பிரச்சனை தான் நமக்கு. ஸோ அதுக்காக தான். ஸோ அதே மாதிரி காஃபோட டைம் லைன் வந்து போக போக இன்க்ரீஸ் ஆகுதா டிக்ரீஸ் ஆகுதா கம்மியாக, டெஃபினெட்லி இன்க்ரீஸ் ஆகுது அப்படின்னா செகண்டரி பாக்டீரியல் இன்ஃபெக்ஷனில் கூட இன்க்ரீஸ் ஆகலாம். பட் இருந்த காஃப் முதல்ல இருந்த காஃப் ஒரு 10 days டைம் லைன் அப்படின்னா 10 daysக்கு இருந்த காஃப் முதல்ல இருந்ததுக்கு சேமாக இருக்கா, அதே இன்டென்சிட்டியில் இருக்கா, இல்லைன்னா குறைஞ்சிருக்கா அதிகமாக இருக்கா அப்படின்னு. ஸோ குறைஞ்சிட்டு இருக்கு அப்படின்னா டெஃபினெட்லி வி கேன் டெல். ஸோ இட் டேக்ஸ் ஸ்டில் 2 or 3 weeks டு செட்டில் அப்படின்னு சொல்லிக்கலாம். பட் தர் இஸ் நோ ரோல் ஃபார் நெபுலைசேஷன் தட் பீரியட் ஆல்சோ. அந்த காஃப் நம்மளோட ஸ்லீப்பை டிஸ்டர்ப் பண்ணுது, ஏர்லி மார்னிங் காஃப் இருக்குது அப்படின்னா இட் கேன் ஸ்டில் பி எ வீஸ். ஸோ ஏர்லி மார்னிங் காஃப்க்கு இது மாதிரி ட்ரையல் வீஸ், இந்த ட்ரையல் நெப் கொடுத்து ரெஸ்பான்ஸ் இருக்குது அப்படின்னா தாராளமாக கொடுக்கலாம். பட் தெர் இஸ் நோ ரோல் ஃபார் giving any antibiotics unnecessarily for the child. So the child is thriving well, சாப்பிட்றதுல பிரச்சனை இல்லை, விளையாடுறதுல அதோட ஆக்டிவிட்டி நல்லா இருக்கு, அது பாட்டு இருமிக்கிட்டே விளையாடுது. ஒரு நாளைக்கு நம்ம ஜஸ்ட் ஒரு மைல்டு மாடரேட் சிவியர் காஃப்னு வச்சுக்கலாம். ஒரு நாளைக்கு ஒரு 10 to 20 times காஃப் பண்ணதுன்னா அது நார்மல், ஒரு 20 to 50 times நார்மல் ஆகுதுன்னா அது சிக்னிஃபிகண்ட் காஃப் அப்படின்னு சொல்லிட்டு நம்ம கிரேட் பண்ணிக்கிட்டு இதை வந்து சப்போர்ட் பண்ணிக்கலாம்.
So we should spend some time with the parents for counseling that this child doesn't require cough suppressant, but if cough is persistent and progressively increasing, we have to think of some other cause. So coming from OP to IP management, so another common thing is giving oral steroids in bronchiolitis. So when should steroids be used in a hospitalized children with bronchiolitis and viral wheeze? What are the risks, theoretical risks associated with steroid use?
So, in a child with bronchiolitis, I would refrain from giving any sort of steroids, be it nebulized, oral, or IV. Viral wheeze, I think it is pretty clear that everybody does give steroid in some way. So, nebulized steroids 100%, and if a child with viral wheeze gets admitted, we are going to give oral or IV steroids. The problem is in those 1 to 2 year children who you are not able to clearly differentiate whether it's a bronchiolitis phenotype or a viral wheeze phenotype. So as Dr. Karthik already mentioned, what I do is in that 1 to 2 year children, when they come, I give a trial of back-to-back bronchodilator nebulizations. If the child does respond to it, then there is obvious bronchoconstriction. That is the physiology. I am going to give steroids. Whereas if there is no response, or I'm pretty clear this is bronchiolitis where there is only crackles and no wheeze, I would refrain from giving steroids. So the problem with steroid use is that, as Dr. Karthik said, the bronchiolitis event is taking a long time nowadays. So what used to be 7 days, so we used to say the exact timeline when I was a PG. So it increases by 4th day, comes down by 7th day. Now it increases by 2nd day, comes down by 12th day. So the child would have met 4 or 5 pediatricians in that time, and each would have given 2-3 doses of steroids. Cumulatively, that adds up. So cumulatively, that causes a lot of issues. So in bronchiolitis, if I'm sure it is bronchiolitis, I refrain from steroids.
So what are the clear indications for starting antibiotic despite a confirmed viral infection, the PCR is positive, still, when we have to consider starting antibiotic, and if at all we are starting, what should be our antibiotic of choice?
So only in ICUs, as I already told, secondary bacterial
Secondary
infection is more common in ICU children, around 40 to 50%. That time you can't wait for the results to come to blood culture. So even if you take blood culture, it is only positive in less than 10% cases in pneumonia. So there is no point in waiting for that child. So in ICU child, don't ever think, you can straight away start antibiotics. So as I already told, streptococcus pneumonia and staph aureus is most common. So instead of ceftriaxone, it's better to go for amoxiclav in ICU settings. Only if there is a severe infections, if the child is having along with shock, you can try adding a MRSA coverage also in vancomycin. So otherwise, for routine IP patients, in ward patients, there is not at all need for adding IV antibiotics.
Sir, how common are co-infections in children? We can see if we send respiratory viral panel, it may show two to three viruses positive, and one virus positive and mycoplasma positive. So how common are co-infections, and how to differentiate a viral LRTA from an atypical infection? The lot of atypical infection we saw in that early part of this year. So how to differentiate?
Yeah, most of the time this RSV adeno are common, RSV rhinovirus is common, influenza adenovirus is common. So previously told this, I told right, RSV, this even mycoplasma, it can last for even 6 to 8 weeks in nasopharyngeal swab. So அதை வச்சு நம்ம இது பாசிட்டிவ் கோ இன்ஃபெக்ஷன் சொல்ல முடியாது. It can be either previous infection also. And viral LRTA from atypical infections, ஸோ மோஸ்ட் ஆஃப் த டைம் நம்ம புக்கை படிச்சுட்டு சொல்கிற மாதிரி 5 இயர்ஸ்க்கு மேலே ஏடிபிக்கல் இன்ஃபெக்ஷன், லெஸ் தென் 5 இயர்ஸ் வைரல் தான் காமன் அப்படின்னு சொல்லவே முடியாது. ஏன்னா இப்போ எந்த இன்ஃபெக்ஷனும் புக்கை படிச்சுட்டு வரதில்லை. ஈவன் 2 இயர்ஸ்லுமே நம்ம வந்து மைக்கோபிளாஸ்மா அவுட் பிரேக் பார்த்தோம். ஸோ ஈவன் இன்ஃப்ளூயன்ஸா கேன் அக்கர் ஈவன் ஆஃப்டர் 5 இயர்ஸ், ஈவன் இன் ஹெல்த்தி சைல்டு, கோமார்பிட் சைல்டு இல்லாமல். ஸோ இப்போ ரீசன்ட் கைட்லைன்ஸ் எல்லாருமே சொல்கிறது வந்து ஈவன் ஆஃப்டர் 5 இயர்ஸ் கூட இன்ஃப்ளூயன்ஸா வேக்சின் போடுங்க, ஈவன் இன் ஹெல்த்தி சைல்டு அப்படின்னாலுமே. ஸோ some of the differentiating features, LRTA, there will be a coryza, and there will be a wet cough, and the onset will be acute. So sudden onset இருக்கும், 1 to 3 daysல நல்ல ஒரு high grade fever இருக்கும், மூக்கொழுகும், இருமல் இருக்கும். பட் ஏடிபிக்கல் இன்ஃபெக்ஷன்ல ஒரு ஃபீவர் மட்டும்தான் இருக்கும். மெயின்லி ஸ்டார்ட் அஸ் ட்ரை காஃப் அண்ட் பேராக்சிசமல் காஃப், போஸ்டசிவ் வாமிட்டிங் இருக்கும். லேட்டர் சேஞ்ச் டு 7 to 10 டேஸ்க்கு அப்புறம் ட்ரை காஃப் இஸ் சேஞ்ச் இன் டு வெட் காஃப். அண்ட் சப்அக்யூட் ஆன்செட், இன்சீரியஸ் ஆன்செட்டாக இருக்கும். 5 to 7 days பர்சிஸ்டண்ட்டாக ஃபீவர் இருந்துகிட்டே இருக்கும். ஸோ அது சம் ஆஃப் த கிளினிக்கல் ஃபியூச்சர்ஸ். அண்ட் ஈவன் அசோசியேட்டட் சிம்டம்ஸ் கூட இருக்கலாம். இப்போ ஏடிபிக்கல் இன்ஃபெக்ஷனில் டிரான்சமினட் சொல்லலாம், ஓரல் அல்சர்ஸ் வரலாம், எம்ஐஆர்எம்மாக ப்ரெசென்ட் ஆகலாம். ஸோ எக்ஸ்ரேல பார்த்தா பெருசாக வைரலில் வந்து பயோலெட்ரல் இன்ஃபில்ட்ரேட்ஸ் இருக்கலாம். இதில் வந்து எந்த அளவுக்கு சிக்னிஃபிகண்ட் காஃப் இருக்கும், பட் எக்ஸ்ரே ஃபைண்டிங்ஸ் நார்மலாக இருக்கும். இட் கேன் பி எதர் நார்மல், இல்லைனா எதுவுமே இல்லாமல் இருக்கும். நம்ம நிமோனியானாவே காஃப் கம்மியாயிரும், ரெஸ்பிரேட் டிஸ்ட்ரெஸ் தான் ப்ரிடாமினண்ட்டாக இருக்கும். பட் ஏடிபிக்கல் இன்ஃபெக்ஷனில் ரெஸ்பிரேட் டிஸ்ட்ரெஸ் ரொம்ப ப்ரிடாமினண்ட்டாக இருக்கும், ரொம்ப மைல்டாக தான் இருக்கும், சிக்காக இருக்க மாட்டாங்க. ஸோ இதெல்லாம் சம் ஆஃப் த கிளினிக்கல் ஃபீச்சர்ஸ்.
Okay, sir. And another commonly used drug is azithromycin in our OPD practice. So is there any role of azithromycin in viral pneumonia or bronchiolitis? Because some of the textbooks say you use it as an immunomodulator.
In acute scenarios, no, sir. So in acute scenarios, azithromycin has zero immunomodulatory effect. So we do use azithromycin for conditions like PIBO, cystic fibrosis, bronchiectasis, but there they say effect starts after 3 months of alternate day use. So in a documented viral pneumonia or bronchiolitis, there's no role of azithromycin. The problem is, as Dr. Karthik said, previously it was easy to differentiate. Till last year this question would have been easy. It is easy to differentiate mycoplasma atypical from atypical bronchiolitis. So last year children presented as typical bronchiolitis but went on to have a difficult course where with BioFair we found out that they were mycoplasma. So last year was difficult. We were overusing azithromycin to some extent. But in the current epidemic seems to be predominantly RSV. We're not finding much of mycoplasma. So right now azithromycin should be 2-3 steps down is what I feel. So again,
ரொம்ப நேரமாக நாங்கள் டயர்டாகிட்டோம். நான் உங்களை கேட்குறோம். ஸோ நீங்கள் அதுக்கு அப்படியே ஆன்சர் பண்ணியிருப்பா ஐசியூ மேனேஜ்மெண்ட்டுக்கு.
So sir, this is a question which I really wanted to take. So even during PGs, every disease or every consultant had their own threshold of normal oxygen saturation. Some say that it should be more than 98 you give oxygen. Some say it is 92, 94. Some, even if it's 100, a child has distress, you just keep oxygen. So what do you follow? What do you think is the normal threshold?
See, I follow. If you look at the guidelines, any saturation less than 94% will be considered as a respiratory failure. So in that condition, we have to start oxygen. But in bronchiolitis, the cutoff is different. Bronchiolitis, children usually have lower saturation level. So the saturation cutoff for bronchiolitis as per WHO recommendation is 90%. I usually follow this 94% guideline only, because why we have to take risk. So if the saturation is less than 94% and the child is having clinically distress, I will start oxygen. Whereas in OP practice, if the child is alert, active, not much distress, but saturation is fluctuating. Sometimes it is coming around 90, sometimes it is coming around 94. At that time, I won't suggest oxygenation.
So, and the second thing, almost most of the children which I'm admitting have some subcostal retractions, and in a child with nasal block, cough, feeding will obviously be reduced. So what we are taught as PGs when we were PGs was, okay, feeding not well, retractions, you should start HFNC or do things. But what I noticed is even milder bronchiolitis, the child does not feed as well and the child does have some amount of subcostal retraction. So what are the objective parameters that you use when deciding which child requires HFNC?
As you said, the only proven therapy in bronchiolitis is a gentle nasal suction intermittently, and we have to give adequate hydration. These are the only proven therapies. And so most of children who are already on nasal prong oxygen, if the child continue to have respiratory distress, if the respiratory rate is more than age specific cutoff value, associated with significant retraction, because bronchiolitis children usually have some amount of retraction, some amount of tachypnea. So the threshold for starting HFNC would be little high when compared to a viral pneumonia or community acquired pneumonia. So if the respiratory rate is very high, associated with retraction, or if the child appears to be lethargic, and if there is a recurrent apneic episodes, then I would consider starting the child on high flow nasal cannula.
Do you recommend VBG, sir? Would you have some or an ABG, some PCO2 or PO2 cutoffs for deciding this?
If the child is maintaining saturation and alert and active, I won't suggest ABG. But if the child appears dull looking, lethargic, I will suggest doing ABG to look for respiratory acidosis. So in the respiratory acidosis also, first you start HFNC, then repeat ABG after 2 hours. If it is resolving, continue. If it is persistent or worsening, you have to hike up the respiratory acidosis.
Sure. So again, following up on the point that you just mentioned, so I see a child, I admit the child has increasing distress, I put the child on HFNC. I notice that the child continues to have respiratory distress on HFNC. So now I'm confused. Okay, should I just wait and watch 2 more days because it's a bronchiolitis, it is going to be there, or should I hike up certain put? Should I go for an NIV or invasive ventilation? Again, what are the parameters here that you look for?
So again, I'm telling repeatedly the same thing. The cutoff for other conditions and cutoff for bronchiolitis will be little bit different. If the child remain alert and active, but retractions are there. For example, if a 2-month-old child having respiratory rate of 60, even on HFNC with retraction, but the child alert and active, I would like to continue the child on HFNC because it will take time for to resolve. Usually in other conditions, when we start HFNC, at the end of 2 hours, we assess whether it is a HFNC failure or not. If we think it is HFNC failure, we will hike the NAV support. But in bronchiolitis, it is a bit different. Again, even after starting HFNC, if the child appears dull looking, lethargy, and blood gas suggestive of persistent respiratory acidosis and pH less than 7.2, and still apneic episodes are persisting, or if with the HFNC, the FiO2 requirement is high. If it is going more than 50%, I would like to start the child on NIV. If NIV is not available, I would directly go for intubation.
So again, most infectious disease people and even to an extent intensivists consider oseltamivir and ribavirin in immunocompetent children as more or less placebo.
Yes.
So at least what I've been taught in my PG was oseltamivir does not reduce intubation, does not reduce ICU stay, does not prevent death. So it is not a great drug. It is at best an OP drug to reduce fever is what I've been taught. But in a child where on HFNC you are contemplating intubation, is there any role for trying these agents? Now you know that RSV and flu are the common infection. Is there any role for ribavirin and oseltamivir in an ICU setting?
So mostly children who are admitted in ICU would prefer doing nasopharyngeal swab PCR or ET aspirate PCR. So the report will be available by the next day. So oseltamivir ideally should be started within 48 to 72 hours in a stable child. Whereas in a sick child, even if you start later, definitely it is going to decrease the viral load. And some retrospective studies have shown that uh, starting oseltamivir will reduce the duration of mechanical ventilation in ICU stay, even though it doesn't show any mortality benefit. So I would prefer to start the child, any child with influenza on HFNC or mechanical ventilation or other system involvement. I would start the child on oseltamivir. So the typical course will be we are giving BD dose for 5 days. But in an intubated child, if the viral load is high, we can extend the duration up to 10 days also. So coming to the other drug, the ribavirin. Ribavirin generally it's not indicated in RSV bronchiolitis. Only the nebulized ribavirin, that is inhaled formulation of ribavirin, is indicated only in some certain specific group of children only. And nebulized ribavirin is currently not available in India. Only oral ribavirin is available. Only if it RSV bronchiolitis with high viral load and got intubated, or severe RSV bronchiolitis requiring HFNC intubation with immunocompromised state or comorbid conditions like cystic fibrosis. In those children only, I would consider starting oral ribavirin. Again, oral ribavirin is not having much effect. Only studies have shown that in immunocompromised children, children with post bone marrow transplantation, oral ribavirin has shown some effect, that is reducing the duration of ventilation, and it helps to wean the child rapidly from oxygen support. Again, ribavirin has its own complications. It can significantly cause gastritis and it can cause hemolytic anemia also in some individual. So whenever we start ribavirin, we explain this side effects to parents, then only we start.
Another question which pediatricians commonly ask me is that do you use nebulized adrenaline for bronchiolitis? So, since we are saying that no need for bronchodilators, it is only secretions, the immediate question they ask is, okay, can we use adrenaline? That does reduce secretion. So, for a normal child, I would upfront say no. So, in a child with HFNC, you know that intubating bronchiolitis is going to come with its own challenges. Is there any role or any benefit trying nebulized adrenaline?
Again, if you see the literature and guidelines, they will say adrenaline doesn't have any role. But clinically, I have seen responses. So I commonly use adrenaline nebulization in my ICU. And mostly it is also like a trial and error method only. When I start adrenaline nebulization, if it has decreased the respiratory rate and work off breathing little bit, I will continue. Otherwise, I won't. So coming from management, the next part, this is some of the data that is I want to show the data from our pediatric ICU in HDU. In the last 2 months, we have total of 148 children admitted in our PIC1 HDU. Among that, 59% children were of children with lower respiratory tract infections, and among that, 58 children were of viral bronchiolitis. In that, 50 children we sent RSV and flu PCR. So 42 children came out to be positive for RSV, and none of the children with viral bronchiolitis are positive for influenza. Whereas in viral pneumonia, that is this bronchiolitis and pneumonia, we have differentiated based on the point of care ultrasound finding. Children who showed some sort of consolidation, we classify as a pneumonia. So 18 children were of pneumonia. In that, we sent RSV flu PCR for 10 children. 7 were of RSV positive, and 2 children were of influenza positive, and 1 child was enterovirus positive. And in bronchial asthma, total we had 6 children. In that, 2 children we sent PCR, 2 of them were RSV positive. And among those 88 children, 60 children required nasal prong oxygen, 22 children required HFNC, and 6 children required invasive mechanical ventilation. Luckily, in the last 2 months, we didn't see any mortality because of RSV bronchiolitis.
That because of you.
So, moving to the next part, that is complications of RSV infection bronchiolitis. Sir, are you seeing kids who are getting admitted, then get discharged, and after 1 week or after 5 to 6 days, again presented with persistent cough, wheeze, and respiratory distress?
Even children who are not recurrent wheezers, I'm seeing this trend. So bronchiolitis, 4-month-old bronchiolitis gets admitted, goes on HFNC, gets discharged. Couple of weeks back, comes back saying that child is still coughing, or child was well for 3 days and is coughing back. So what the problem with the current season is that every time it rains, it seems the new strain of RSV comes in and infects the children. So even my own son had 3 separate episodes of fever and cough since Diwali. So even in children who are not known wheezers, we are noticing this trend of recurring events. So the children at risk, if you ask me, the uncontrolled wheezers, the children who are on not proper compliance and those sort of things, they are coming back much sicker. So you give steroids, nebulizations, do a lot of things, reduce the wheeze, immediately one more infection, it flares up. So it is the segment of children with poorly controlled wheeze who I would say are at a much higher risk. Other than that, it's the common thing. So children with BPD, children with any sort of congenital heart disease, nephrotic syndrome, those children are also at a higher risk of repeated viral infections in the season.
So those children who are presenting with recurrent wheeze because of this viral illness, would you prescribe
I would
controller therapy for
prescribe
them?
ICS. I mean, even if the child does not have any features of atopy, although IG is not of much use, say everything you do is normal. The children has, if the child, especially an older child, 1 to 2 year, repeated episodes of wheeze, I would say please be on ICS till the winters go by, because we don't want to risk one more episode of viral triggered wheeze.
So what are the other complications have you observed in this viral epidemic, predominantly in children with influenza infection? What are the other complications you have observed other than respiratory involvement?
So most of the time, post influenza, starting from CNS, ANEC is a most severe and fatal disease. So it can cause acute necrotizing encephalopathy of childhood. There is an entity called IAE, influenza associated encephalopathy or encephalitis. So even it can cause meningitis, encephalitis, and GBS, ADEM. It can all cause for CNS. In heart, if you see, rarely it can cause myocarditis also. And liver, transaminitis, mild transaminitis can. But most of the children is having myositis. It's more common in influenza post, even in at the present of acute influenza infection. Viral myositis is most common. CPK will be grossly elevated in those children. So just a hydration is a treatment. So proper hydration is a treatment. So transaminitis and some rare children can have HLH trigger.
So apart from involving the respiratory tract, influenza can also cause varied CNS manifestations, starting from simple influenza-associated encephalopathy, where the MRI picture will be normal and CSF picture will be normal, just nasopharyngeal swab will be positive, to acute necrotizing encephalopathy, where we will have typical MRI findings. And as Sir said, it also involves the heart, it also the liver. Some children presented with acute liver failure also in our ICU. So influenza not only involve respiratory tract, it can involve other organ systems also.
Plus, most of the time in flu, most of the time some are giving aspirin, brufen. It will even exacerbate the Rey syndrome also.
So again, a question to you, sir. So PIBO, that is post-infectious bronchiolitis obliterans. When did you suspect PIBO in a child with initially had viral bronchiolitis? And have you observed any cases of PIBO in this RSV season?
In this RSV season, we don't see PIBO till now. But most of the time, post RSV or post adenovirus or post mycoplasma, post flu, these PIBO can occur. So when you if the child is having persistent respiratory distress for more than 6 weeks, or hypoxia, or persistent chest signs, and wheezing, not responding to bronchodilators, and exercise intolerance, so that child we can think of PIBO. So it's a treatment is totally differentiate. It's a lifelong treatment. As the child goes by around 30 to 40 years, they will overcome these conditions, most of the child. So it's a totally different entity, but most of the time post RSV, post adeno, PIBO is common. Only think of PIBO when the child is having persistent symptoms even after 6 weeks.
So if a child is having persistent symptoms even after 4 weeks and 5 weeks, so what should the pediatrician should do? How he can diagnose PIBO?
It's better to refer
The
to
child to
pulmonologist.
So the next question comes to Dr. Manoj. So what complication require referral to a higher center in a child with bronchiolitis?
So again, a referral to a pulmonologist and referral to an ICU are two different aspects. So a referral to a pulmonologist, if the child has any pre-infective or risk factors even before the infection. So if the child is failing to thrive and has a severe bronchiolitis, the child presents with a bronchiolitis like event and you notice a severe anemia. So pulmonary hemosiderosis is something that presents like this. So child with the background bronchopulmonary dysplasia presenting with these things. And as sir mentioned, any bronchiolitis where the cough does not settle for more than a month. So these do warrant pulmonologists to have a look. So that is as in terms of a pulmonologist, whereas in terms of ICU, I think you would be the better person. So I would say the other system manifestation.
Yeah,
Anything
as we
which
have already discussed, any child with clinical red flag signs like persistent respiratory distress in spite of adequate oxygen support, or lethargy, recurrent apnea, and having respiratory acidosis, or other system involvement, child is having shock. So these children should be referred to a center where ICU facilities available. So coming to our last part of discussion, that is prevention of respiratory viral infection this season. So Karthikeyan sir, what is the best timing for influenza vaccination in our Tamil Nadu, and which age group should be prioritized?
Okay. ஸோ நம்ம ஊரில் செப்டம்பர் டு டிசம்பர் தான் மான்சூன் சீசன். ஸோ அக்டோபர் டு டிசம்பர். ஸோ இட்ஸ் பெட்டர் டு ஸ்டார்ட் 1 month பிஃபோர் த சீசன். தட் இஸ் த ஐடியல். ஈவன் அக்டோபரில் வந்தாலுமே இட்ஸ் பெட்டர் டு கிவ். ஸோ தி சீசன் முடிகிற வரைக்குமே கொடுக்கறது தான் பெட்டர். ஸோ இட்ஸ் குவாட்ரிவேலண்ட் இஸ் ஆல்வேஸ் ப்ரிஃபரபிள். பட் இப்போ ட்ரைவேலண்ட்டே போதும்னு சொல்லியிருக்காங்க. பட் இட்ஸ் பெட்டர் டு ப்ரிஃபர் குவாட்ரிவேலண்ட் வேக்சின்ஸ். ஸோ நம்ம ஊரில் நார்தன் ஹெமிஸ்பியர் ஸ்ட்ரெயின் தான் காமன். ஸோ இட்ஸ் ஆல்வேஸ் பெட்டர் டு கிவ் இன்ஃப்ளூயன்ஸா 1 month பிஃபோர் த சீசன். அவ்வளோதான். ஸோ இந்த less than 5 years இட்ஸ் மஸ்ட். அட்லீஸ்ட் 6 months வந்து ஃபஸ்ட்டு 2 years அது ரொம்ப ரொம்ப இம்பார்ட்டண்ட்டு. ஸோ 2 years தான் ரொம்ப காமன்னு. ஸோ வாட் சஜஸ்டிங் இஸ் ஐஏபி சஜஸ்ட் less than 5 years. And especially if there is a comorbid conditions, chronic lung disease or asthma or wheezes or immunodeficient child, any with renal disease or liver disease, better to give for all children irrespective of age group. And ஹெல்த் கேர் ஒர்க்கர்ஸ் நம்ம எல்லாருமே இந்த டைமில் போகிறது ரொம்ப ரொம்ப இம்பார்ட்டண்ட்டு. ஸோ இவங்களுக்கெல்லாம் பண்ணுறது பெட்டர்.
Since we are talking mostly about RSV infection, so is there any way to prevent?
So previously, the only drug for preventing RSV used to be pavlizumab. So pavlizumab was hugely expensive. It was a monthly injection that the child has to take for every month of the season. So as sir said, you give one injection in September, October, November, December, January, and February, which is both highly expensive and no parent is going to come every month for an injection. Now nirsevimab is currently available in India. So it is as efficacious. It is non-inferior to pavlizumab. One injection works for the entire season. So it says it works for, at least studies say it works for 6 months. So similar to flu vaccine, you get a shot in July, you're sort of covered till January. So that is going to change how we look at RSV infections in the future. Regarding who to suggest, so AAP has come up with a recommendation. AAP recommends that every child less than 1 year should be given the vaccine, and for children between 1 to 2 years, the ones who have comorbidities, the ones with immunodeficiency, any chronic lung disease, chronic heart disease, nephrotic syndrome, on steroids, on long-term steroids, all of these children, even between 1 to 2 years, should get vaccinated. However, should get the monoclonal antibody, passive immunization. So in India, I don't think giving it for every child is feasible. So a single shot costs almost 40 to 60,000 rupees. So even in Kauvery, we were having a discussion. So at least the most susceptible population, the preterm children, those with BPD, those with congenital heart disease, those on chronic steroid therapy, I think we should start vaccinating them with nirsevimab.
So as Dr. Manoj said, currently we don't have any active immunization, that is vaccination for children. For children to prevent RSV infection, we have only monoclonal antibody. Initially we used pulmonologist. Now it's nirsevimab is available, and the AAP now recommends to use nirsevimab instead of pulmonologist. And RSV vaccination is available, that is only for elder age group, that is people more than 60 years old and pregnant mothers. So if you vaccinate the pregnant mother, will it prevent RSV infection child?
First 6 months.
Yeah.
So what they say is, if the mother is vaccinated, you don't have to give nirsevimab for the first 6 months. So it will be covered for that season. You can give it for the next season.
Okay. So with that, we have come to the end of the discussion. So